Great. Just so you can all be sure that your sound's working, I'm just going to say hello to you all. And it is just good afternoon by a couple of minutes. So my name's David Byrne. I'm the director of the Academic Health Science Centre, Newcastle Health Innovation Partners, and also Pro-Vice Chancellor for the Faculty of Medical Sciences. And it's really great to see so many of you joining, and I think a few more will probably continue to join as they leapfrog between meetings and calls. But just by way of introduction, we're absolutely delighted to have Hamish here, Hamish McAllister-Williams. I've known Hamish for more years than he and I probably care to say. He's been a leading light in the international, national, as well as regional picture of treatment-resistant depression. He's been a stalwart clinically in CNTW for many, many years, our very large mental health trust. And is now championing research within that organisation at a broader level. And most recently, Hamish has been very heavily involved in a theme within the prestigious NIHR Biomedical Research Centre, particularly along the lines of mental health in physical illness. And indeed, that is the angle that he's going to take for his talk today. So I think all of us know the challenges of mental health, either at a personal level or from those that we know who've got issues with mental health or had problems with mental health. And obviously, older people or younger people with physical issues are, if not more susceptible, they're certainly victim to this problem as well. And so it's really timely that Hamish is going to step up and talk about this. I was going to pass comment that apparently, Hamish, yesterday I was reminded is known as Blue Monday, which yes, apparently is where everybody feels they've just got like back at work after Christmas and survived all of that, and then they have a bit of a dip. So I wasn't aware, or if I was, I'd forgotten. But yesterday was Blue Monday, but now we're on to Happy Tuesday. So over to you, Hamish, and he's going to speak for about 16 minutes. We allowed him a minute's scope on his talk. And then obviously, if you have any questions, either put them in the chat, which would be great, or pop your virtual hand up and I'll bring you in. It would be lovely to have some interaction after Hamish's talk. Over to you.
Great. Thank you very much indeed, David. Yes, and Blue Monday yesterday. And I'm going to be mentioning blue, but actually I went out for a walk with my granddaughter yesterday afternoon, and getting out into a green space was really important. And I'm going to come back to that. So as David says, I've actually got a foot in two of the partners of NHIP, both working within CNTW Trust as well as the university. I'm going to really try and look at why mental health research can be so complicated. And I suppose I'm going to be asking you to consider whether you think this is more complicated than other areas of medicine or not. I think it is more complicated. I'm going to say quite a bit about, or imply, that this complexity is really important in terms of how we do research. But the complexity is also very much why this area is so interesting. And I'm going to end just by saying something briefly about how NHIP can help. So I suppose the first question is, why wouldn't mental health research be complicated? The brain is arguably the most complex organ in the human body. The figure that I found on the internet was saying the brain is the most complex, mind-blowing organ in the universe. I think that's probably a little bit presumptuous because we don't know what other life forms there might be in the universe. But on Earth, I think it probably is the most mind-blowing organ. 85 billion neurons. That's an awful lot of nerve cells in the brain. But that's not really what makes it so complicated. It's the 100 trillion connections between those nerve cells. And we see beautiful connectivity in small local regions of the brain. This is a little bit of the hippocampus. But we also see beautiful connections throughout the brain. These colored strands are demonstrating the connections between different areas of the brain. And it is a very complex, interconnected system. where we have networks of neurons all working together, controlling different functions. Functions are not located anatomically in single places in the brain generally. They're more controlled by networks that cross different regions of the brain. What we often forget as well is that while we have 85 billion neurons, we have 85 billion glia cells within the brain. These are the cells that support neurons, and they do influence the activity of neurons. So we sometimes forget about that, and there's less research in many ways that looks at the impacts of glia. But this is an incredible level of complexity. The brain is often referred to by some people, or what the brain does, as being the mind. And I think this is another area where the brain is perhaps a little different to other organs within the human body. I don't think there's another organ of the human body that has generated the amount of philosophical debate that has been going on for many centuries. René Descartes is reputed to have said, "I think, therefore I am," from the 17th century. He was a dualist. He considered that consciousness, or the mind, exists independently of the brain. That leads to a problem, because how does consciousness actually affect physical reality? I'm perhaps more of a monoist, thinking that actually these things are subsumed together. You might think this is a sort of, oh, it's just a philosophical debate. But we do have researchers working in mental health that are more focused on the mind, and we do have people working in neuroscience that are focused more on the brain. And what I would argue is that thinking of the brain without considering the mind is mindless, and thinking about the mind without considering the brain is brainless. We need to think about these things together. The brain interacts with every part of the human body. It does obvious things like control our movements, but it also controls a lot of our functions within our body, our heart function, respiratory function, gastrointestinal function, and also the immune system. The immune system and controlling the immune system is incredibly important, because if you activate your immune system, you get mental health symptoms like low mood and fatigue, and you also get lots of physical health problems, and physical illnesses often activate the immune system. It's a bi-directional point of interaction between the mind and body. And just to think about just the subtlety of how the mind can influence the body, I was interested about this paper that I came across just the other day. This comes from San Diego, published during 2023, which looked at the importance or impact of giving acts of kindness of individuals, either to other individuals or to society. What they demonstrated in a large cohort of about 750 individuals, they demonstrated the dose-response relationship between the amount of giving and reductions in inflammatory markers in those individuals that's not seen with receiving. So it's argued by some people that acts of kindness lead to physical health changes. I think that's a really interesting example of just the subtlety that we can see in those interactions. The brain obviously also interacts with the environment. It's our main organ for allowing us to interact with the environment, both in terms of taking in sensations through the ears, eyes, nose, mouth, but also controlling our activities and our engagement with the environment. We know that the environment can have a massive impact on the brain. These are photomicrographs showing the impacts of stress on nerve cells in animals, showing that the complexity and the number of branches that these nerve cells have are reduced in stressed animals, and the number of connections that the nerve cells have with other nerve cells is also reduced by stress. It's really quite dramatic. And to think that we've got 100 trillion connections, and that a number of those connections will be influenced by the amount of stress that we are under. Now, the environment clearly interacts with biology, But it took us a long time before we got good examples of that interaction in mental health. This is one of the best examples of that that was shown now 20 years ago. This looked at the relationship between the number of stressful life events and the probability of getting depressed. And not surprisingly, the more stressful life events you have, the more likely you are to get depressed. However, this is modified by a number of biological factors, one of which is a gene. It's a gene for the 5-HT transporter protein. And this gene can come in two different forms. It can either be or the protein that it codes can either come in two forms, a short or a long form. There's a little bit of it that gets repeated multiple times. And we carry two of these genes, and you could have two long forms. You could have a long and a short, or you could have two short forms. And those individuals who have two short forms of the gene seem to be particularly susceptible to developing depression when stressed, whereas those with two long forms of the gene seem to be more resilient. So this is a good example of where the environment does impact the brain, but the biology of the brain also then impacts that or interacts with that, influencing the nature of the issues that arise. I said that I went out for a walk yesterday to combat the impacts of Blue Monday. There is evidence that engagement and being close to green or blue spaces can lead to an improvement in life satisfaction and also decrease the risk of both mental and physical illnesses from cross-sectional studies. The longitudinal studies are a little bit more equivocal. It depends possibly on the nature of the green space. For example, the amount of tree cover seems to influence the likelihood or not of developing depression. There's also a question about what is it about these spaces that leads to alterations in mental health? Is it getting involved in things like activity in these spaces? Well, activity is known to have positive effects on mental health, but a lot of these effects of green and blue space don't seem to be, the mechanism of action doesn't seem to be simply through increasing levels of activity. To illustrate that, this is an interesting study coming from California, from Palo Alto, that looked at the impact of individuals walking through either rural or urban space. And what they demonstrated was that when individuals walked through rural space, they had less rumination about negative things. But they also saw differences in blood flow in the brain. We're seeing direct biological effects in the brain simply of the environment that people are walking through. I think it's incredible. That effect can be replicated just by showing people photographs of either rural or urban scenes. And if you pixelate those photographs and randomize the pixels, you get an effect of rural scenes, which possibly is related to the amount of green in those images. So actually the color green itself may have positive advantages. So mental health research is complicated. It's complicated also by what we're actually investigating. We sometimes refer to mental health, or increasingly people talk about mental health, as if mental health is a bad thing. I've got mental health. That's great. I would say to somebody, if you've got mental health, that's brilliant. I've got physical health. Thank you. I'm feeling fairly fit and healthy at the moment. So sometimes people then talk about mental health problems. What exactly is that? Is that the same as just not being very physically fit? I think personally there is an issue with those terms, because I think mental illness is a more appropriate term for describing something that would lead somebody to be seen by health services. So I do think there is a distinction between mental illness and mental problems, and conflating mental illness with mental health problems, I think, causes problems with regard to how we help people with those mental health problems and how mental health services are actually constructed and managed. Secondary care mental health services like CNTW are, in theory, deal with just severe mental illness. These would be things like psychosis, schizophrenia, severe depression, bipolar disorder, dementia, and so on. We also have a problem of a lack of diagnostic tests. Now, that is seen in other areas of medicine as well, so this isn't a unique to mental health. This is looking at one possible diagnostic test. This is looking at an inflammatory marker. And we've got dozens of different studies. Each one of those lines in that graph represents a single study. And there are lots and lots of studies that have looked at the level of inflammatory markers in patients with depression. And overall, there is a significantly higher level of inflammatory markers in patients suffering from depression. The measure of that, Hedges G, is 0.62. A Hedges of G would mean there was one standard deviation difference between people with depression compared to healthy controls. And about a third of people are out with one standard deviation of the mean of a normal population. What all of that means is, while there is a difference in patients with depression, there is a big overlap between people who have depression and people who don't. What that means is this doesn't work as a diagnostic test, even if it is a robust biological finding. There are also groups of people who argue that we shouldn't even make diagnoses for mental illness. There are a number of people who are members of the British Psychological Society who have argued that. First quote there, this article outlines some of the many reasons why we should abandon diagnoses. I think that is very concerning. I think it makes undertaking research at a group level extremely difficult if we don't make diagnoses. Fortunately, not all psychologists agree with that particular approach. The underlying etiology is clearly biopsychosocial, and that's probably the case for all disorders across medicine to some degree or other. And we can demonstrate that very clearly with mental illnesses. We have a range of professionals working in the field: medics, specialists, primary care, public health individuals, just the same as any other area of medicine, nurses and allied health professionals, again, just like any other area of medicine. We also have psychologists involved in a very significant way in helping patients with mental health problems and mental illness. We also have care provided in a range of different settings in community and hospital. Just bear in mind, in hospitals, we're working in separate trusts, CNTW, as opposed to NUF within NHIP. We have a range of interventions: medication, neurostimulation increasingly. These are ways of actually applying electricity or magnetic fields to individuals' brains from external positions, sometimes internally, to influence the activity of neurons. And we have self-help, social interventions as well. But the other major reason that leads to complexity in mental health is comorbidity. Mental health conditions themselves are highly comorbid. About 5.2% of the population has major depressive disorder at any one time. And about 8.8% have generalized anxiety disorder. But of those people with major depression, 3.1% of them, more than half of them, will have both. So actually, there are fewer people with major depression without generalized anxiety disorder than have both of them. Comorbidity is the norm. We also see that in patients with physical health problems, very high rates of mental health problems, of depression in patients with a range of different conditions. And that comorbidity has a big impact. So mortality, if you have depression post-stroke, is about 59% higher than if you don't have depression. If you have depression post-MI, it's about 90% higher. It's nearly doubled. And it's even raised in patients with cancer. The impact on admissions, very great. This is looking at the impact of multiple conditions, shown in green here. And with the more conditions, physical conditions that a patient has, the more likely they are to be admitted. Deprivation has an impact. The more highly deprived they are, the higher the rate of admission. But whether or not they have a mental health problem has a bigger effect even than deprivation. These things too obviously interact, because if you're in a more deprived situation, you're more likely to have a mental health problem. So lots of implications. Research into mental illness is complicated by a broad range of confounders, the environment you're in, how deprived you are, etc. And all of that requires more research. And those studies need to be really well designed because of the complexity involved, the number of confounders there are, and they potentially need to be of large size. Brain and mind are not inseparable, or they are inseparable, and research into one without consideration of the other won't get very far, and it requires interdisciplinary collaboration. And those collaborators need to be open-minded to different perspectives. And comorbidity is the norm, and understanding that is critical for the NHS, and any investigation related to long-term conditions, particularly multiple long-term conditions, needs to take into account mental health and the importance of mental health and mental illness. And we need more research into the mechanisms underlying that comorbidity. How can NHIP help? Well, we encompass two trusts that are critical to this, as well as the university. The community site in NHIP has got a mental health roadmap that looks at the key infrastructure within NHIP partner that are involved in all the various different people involved in mental health research. And we're creating a community of practice. And I'd like to thank Beth and Holly for help putting this together, where people who've got an interest in mental health and mental illness can come together and identify others that they may be able to collaborate with. So I'm sorry, David, I've overrun by a couple of minutes, but hopefully that's kept people interested.
Hamish, I think we'll forgive you because that was such an interesting and engaging experience. It was wonderful. Really, really interesting. Thank you. So as I say, to those of you who are attending for the first lightning talk, the deal here is always that we finish bang on time, because then you're more likely to come back, because you know you can set half an hour aside, not for fear of it overrunning. But do raise your hands using the relevant button, or pop a, Holly's just put a link into community of practice, but put a question into chat as well. So all right, well, there's a great question to kick us off. I won't need to use my reserve question just for now. So a couple of things. Kind of have a copy of the presentation from Lucy, but Hamish, do you think mental health is worse now in the wake of COVID? And then Flora's got her hand up, so I'll come to Flora after this.
Yeah, so I think COVID is a really complicated thing. Clearly, mental health was poorer, and there were more mental health problems during COVID. I think primarily because of all of the issues of social isolation. It was interesting talking to patients with mental illness, because some suffered greatly and others actually found it somewhat liberating, because they found less pressure to be going out and interacting with others, which is something that they will often find difficult. So some patients paradoxically found it better. Yeah. What is the situation now as we got past COVID? I think we have gone back largely to the way things were before. I think there perhaps are still more mental health problems than there were, but I think rates of mental illness are probably stabilizing back to pre-COVID levels.
Okay, thanks, Hamish. So we've got a couple of hands up. So Flora, and then to Omar. So Flora.
Thank you. Hi, Hamish. My name's Flora, and I'm a nurse. My area of research is looking at the care of people with serious mental illness in physical acute care settings. And I'm looking at dualism, knowledge gaps, and stigma to kind of understand and improve the care for patients when they're getting care from sort of physical health practitioners. And the thing that I've just come up against over and over again is a health system, and maybe even a society, that's really based on dualism, as you said, on Cartesian dualism, and getting people to kind of embrace and think about, you know, mind and body as one, and to consider those separate things when they perhaps work in one camp and not the other. I don't know. Have you got a magic bullet for that? Or?
No, I haven't. But I suppose what I think that can be helpful is using some of the sorts of examples that I put in my talk, because some of those are very simple, and people can sort of go, "Oh, that's interesting," and they can sort of accept some of those things. And if you accept that, you know, why wouldn't the experience of having a severe mental illness influence your outcome with regard to your physical health problem, or your physical health problem influence the outcome from your severe mental illness? In mood disorders where I work, one common comorbidity is with diabetes. And the interesting thing about that is that diabetic control will often go awry when somebody's depression gets worse and their HbA1c measures go out the window. Conversely, if they're doing okay from a mental health point of view and their HbA1c measures start going awry, I worry, because I think they're then more likely to become destabilized on the mental health side. And I think it is really interesting how you can clearly see that two-way interaction. So
Hamish, I'm going to stop you because you're creating loads of questions here. I've got Omar with a hand up, and then there are at least 3 in the chat. So we'll not get through all of these, but Omar, go for it.
Mine's a very, thank you very much for that, Hamish. Mine's a very super quick one in that will you or do you see a change in the way in which we do general health diagnosis based on, for example, I'm going around in circles here. So the body keeps a score sort of thing, in that a lot of the times you might go to your GP for something physical when the underlying issue is mental, but it's not actually picked up. Are you seeing a change in the way GPs are addressing this sort of thing? Or is there a magic pill?
I think that GPs are very aware of the impact of mental health problems, social problems leading to physical health issues. How equipped they are to be able to address that is a different matter. So I think there is some awareness out there. It could be better, but I think there is a real issue in terms of how we address that.
Thanks, Hamish. I think we're going to have to make this possibly the last question unless you've got a one-word answer. Sarah Verity, who's the sort of next question in line, wondering if you could see any benefits to patients and others experiencing distress of moving away from the diagnostic framework. She was assuming you were talking about Lucy Johnson and Peter Kinderman's work.
Yeah. Okay, so I think at an individual level, you need to be able to conceptualize the patient's problems in multiple ways, and thinking about some of the symptoms rather than the diagnosis may be helpful. But I think that in terms of research, it can be challenging if we do that. Unless we group individuals together to say, these people have got this diagnosis, how do we test out the effectiveness of particular treatments? We can only do that by saying, on average, people with this diagnosis do better with this treatment than with that treatment. So I think we have a real problem if we completely throw the baby out with the bathwater.
Great. And that's a great point to finish on, I think. There are lots of messages. It's fair to say I've not known a lightning talk which has attracted as many comments and questions. I'm normally left to have to try and pick up the questioning, and it's just unnecessary. There's so much going on in the chat. We'll try and capture that for you, Hamish, and send it to you in case you wanted to pick up on any of it offline with any of the colleagues who've joined the call. It just remains for me to thank everyone, or to thank Hamish on your behalf for such a brilliant talk, which has clearly piqued a lot of interest. And I think we're going to have to give that a lot more thought in terms of how we go forward, Hamish. You might get a return ticket sooner than you might imagine because of this. And thanks to everyone on the call for being so interactive and for joining today. I hope that you stay dry and warm. And Hamish, brilliant. Thanks again. And to Beth for organising. All right. Bye for now. Bye, everyone.